can get seated. We are excited to start this launch symposium sponsored by Asahi. Amazing attendance and not surprising because we have an amazing group of faculty here. It's my pleasure to introduce Dr. Okuno. Everybody knows Dr. Okuno is he's actually the age of my son, but he's already a godfather of MSK embolization. And Dr. Osman Ahmed, who was smart enough to move from academic practice to private practice, and of course Kavi, who is in University of Alabama, right?
Not smart enough. Not smart enough to move to OBL.
Not
so,
yet,
yeah,
but
not
you will come. So, thank you, Asahi, for this second year. Last year, I remember it was a full house. Again, this year, full house. Thank you so much for sponsoring this meeting. And without further ado, we are going to go over all the three talks, and then we'll have a question and answer for at the end. So, Dr. Okuno, the first speaker, is going to cover MSK embolization. Thank you.
Thank you, Jafar. Thanks for coming. And I will talk about MSK embolization and the device or the embolic material. And I think I have a talk, the similar thing in other meetings. So maybe some of you have already know these slides, some slides. So please relax and have a lunch. And this is a brief introduction of our OBL. We have two OBL in Tokyo and Yokohama or other sites like Osaka, and totally 7 OBL including angio suits, and also the 3 satellites. And we do basically we do lots of effort to announcing this new technique to the chronic painful patients through the website or through also the reference from the sports physician or orthopedic physician. We are doing lots of things, such as things. And sorry, this is a brief comprehensive list of diseases we can treat with MSK embolization, including not only MSK, but one is osteoarthritis, including, of course, the knee is the biggest, but followed by finger or hand. Hand osteoarthritis is also common. I do not mention today. And also hip osteoarthritis, we do lots of patients. And also the overuse sports injuries is one big topic, and because other treatment option is very limited. And also frozen shoulder. Frozen shoulder is very common, so lots of patients have suffered from the nighttime pain for the 3 months or 6 months or 1 year, and we can make shorten the painful period. So today. And also we do the lumbar or neck pain, I will not mention today, and also the inflammatory arthritis like gout, refractory gout, and also the painful, chronic painful condition of pelvic, like chronic prostatitis or others. I will briefly introduce today. Sorry, I will skip this. The sports injury, we have lots of patients of plantar fasciitis or jumper's knee, and tennis elbow, or Achilles tendinopathy, or hamstrings injury, or others. And let me give you one example of ultrasound imaging. So patient selection of this all of these conditions are based on the imaging. So imaging is very important to the patient selection. So the left imaging have ultrasound and the color Doppler signal in basing to the tendon tissue. These are very important findings. So we can say that this color Doppler signal, there is a grading score, and this is a grade 3 or grade 4, and these larger grade patients will have good response rate. The clinical success rate of grade 3 or grade 4, these patients are more than 90%, so 92% from our paper. So we can say that these patients are good indication. And sorry, I will skip this, but interesting thing is that after 1 year follow-up of the embolization, the right side, you can see the tendon tissue improved and the color Doppler signal reduced and normalized the tendon tissue. So this effect is unusual compared to other treatment option. So in this paper, we have reported the normalizing the plantar fascia thickness from the larger than 4 millimeter previously before treatment to the less than 4 millimeter after the treatment. This changing is also encouraging because this treatment can normalize or improve the tissue integrity or strength. That is very positive things. We also reported the similar thing in Jaffar's knee in an orthopedic surgeon like a sports physician paper, and we described that our embolization treatment patients improved their condition or the quality of the tendon tissue. So far we have performed many cases of tendon disease, but for doing embolization using temporary embolic mainly, but we have never seen the patients of rupture after treatment option, after embolization treatment. That is very different from the results of steroid injection or shock wave therapy, which is a very standard or usual treatment option that might sometimes result in 3% or 10% rupture rate. So it's this information is very important to announce that. Sorry. And this is the important things about the treating the tendon disease or sports injuries. When you introduce the sports injury embolization, the three things is important. One is sometimes we do the second treatment option so it's very important, and posterior second treatment option, and the post-treatment restriction of the activity is very important. So I will talk about this. So basically, after embolization, so we ask patients to gradually recover the intensity of the training. So gradually return to the training after the treatment, and so the intensity gradually improve, 10% increase per week, and start with painless or the minimally painful training. That is very important. So we don't make them to stop the training for 1 month or 2 months. We didn't do that, but we encourage them to start the not painful training, and in 2 days or 3 days, light training. Sorry, I cannot. Okay. So I will talk about the embolic material. So there are the permanent microsphere and the temporary embolic, and we always use the temporary for the overuse sports injury. Because permanent microsphere sometimes causing a numbness or muscle weakness sometimes. So it is very negative for the sports injuries patients, which sometimes contains many young athletic patients. So in our practice, we never experience numbness or muscle weakness after using a temporary and which appropriate size of the temporary embolic material. So even though the temporary, but the size is smaller than 100 micrometer, we will experience nerve damage. So the temporary and larger size, larger than 100 micrometer, is very important. So we use the temporary like this. And this is a photo of neck sphere. Neck sphere is also one there are 4 types: imipenem or NextPF or Lipido or circular beads or others. Other material also come, and we use all of these temporary embolic material. And what's the difference between the permanent and temporary? One is the endpoint is totally different. So when you use the permanent microsphere for the knee osteoarthritis, you have to stop you have to stop to the endpoint is pruning. So if you see the brush disappear, you have to stop. Even those, and you have to remain the main flow. So this is an example of the movie before embolization. You can see the brush from the descending genicular artery of knee osteoarthritis, and right side is the pruning. So you also can see the flow, but you cannot the brush reduced or disappear. This is the end point of the pruning endpoint. But if you use temporary embolic material, you have to be more aggressive. So our endpoint is complete stasis of the main trunk. So this is a movie during our infusion of, I think this is NextPF, but imipenem or other circular beads is also same. So we will keep to infuse until the totally stopping of the stasis. That is a very important. But if you see the data, the doing more aggressive is better. So this is our paper to JBIR to compare the imipenem or NextPF or other temporary, and the results is similar. But for the tendon disease, our results indicating that NextPF is better compared to imipenem for the sports injuries like tendon disease. This is a movie during our procedure to the tennis elbow. So we do, for the tennis elbow, we do the radial access, and inside is a catheter, and performing the angiography from the brachial artery, and the target. You can see the brush, the outside of near the lateral condyle, and we use the microcatheter, Belute, which is very good for the torqueability, and also pushability is very good. So we can reach to the final feeding artery, like a radial recurrent artery. Usually we use a wireless technique. So because this microcatheter have small angle, so we can control and push. So now we reach to the very near place for the brush, and we take a small amount of the embolic material and infuse this, and like this, and do the angiography again. This artery is very small, so easy to reach to the stasis. So 0.2 or 0.3 is enough to reach to the stasis, and giving the saline flush, and doing the saline flush to reach to the stasis, and do the angiography again. This is angiography after infusing the temporary embolic, like that. So after this we wait for 5 minutes or 10 minutes, or selecting other branch, and come back here later and do the second angiography. And if there is a remaining brush, we will infuse more. If we treat the tendon disease, we usually do such a method, like a march time embolization in single session. That is important. So this is angiography of the posterior tibial artery for the plantar fasciitis. So if you see this, you can see. So the final feeding branch of the calcaneus branch from the PTA. So this is a movie. This is a movie when we try to select the final feeding artery of the PTA. It turns out that just using the microcatheter wireless technique was not able to select the calcaneus branch. So we use guide wire and reach to the final feeding artery. Basically, super selective is better compared to the shower from the main trunk. So we will, when we do the Achilles tendinopathy or plantar fasciitis, we want to do more selective, as much as possible. That is our way. But we also developed the technique of direct puncture method. Maybe you know, but this is a movie where we do this procedure. Especially when this is very easy, and we can do the consultation room by using the ultrasound and can puncture the PTA. And with the short axis, you can see the needle tip is now, and we are infusing imipenem in this case, but we also can use a repired or next to F. So this is an easy way. Why we developed these things is that some patients have remaining pain and residual pain after the super-selective embolization, and doing the super-selective embolization again is costly in our country, and patients sometimes request a more cheaper or quicker way to do the additional option. So when we see the patients of tennis elbow, severe tennis elbow, we strongly recommend to do the super-selective embolization first, but after that we sometimes add such a direct puncture method to do the additional option. Okay, so this is usually our protocol for the tennis elbow. So we do the super selective embolization first, but some patients have residual pain. Usually, it's common. So we do the direct puncture method in 1 month or 2 months later. If he needed the second time, but usually one time or second time is enough. So for example, this is an illustration of explaining the direct puncture method to the tennis elbow. We use a tourniquet in the forward arm to block the distal blood flow that we can reduce the blood flow to the distal area. And this is a movie of the direct puncture method to the tennis elbow. We increase the pressure to the calf and to the 200, and puncture the brachial artery. This is very easy. So brachial artery is very large. And infuse imipenem like this. And remove the needle. It's very easy. Easy additional option. Just doing this is not enough. But some patients still have residual pain, so we do this in a 1 minute embolization procedure. And the needle size is 27 or 25 gauge, so it's very easy to manage the patients. This is angiography. We don't need to do angiography during this procedure. We can do in the consultation room, but in this time we do the angiography to see what happened in the direct puncture method. So we can see the correcting the contrast to this area. So so I will skip this, but this is before and after direct puncture method. We can see the reduction of the color flow. So, and this is last slide. Why is the temporary embolization sufficient? So this is a paper from the Kawasaki University to JBIR. I think this is very important. From this paper, they developed a small spot of chronic inflammation spot, and also compared to the normal site, and the normal capillary, normal blood vessels can recover in 70 minutes or 90 minutes after the imipenem blocking or the other like Lipido blocking. But in inflammation nerve vessels, they will reduce in 90 minutes. So the reaction to the temporary embolization is totally different between the normal blood flow and the inflammation vessels. That is very important, why we can use the temporary embolic material for this field. Okay, Jafar, thank you. Thank you. So
interesting. Every time you come with a new technique, yes, this is this is unbelievable. We will keep the question for the end. So my pleasure to invite my little brother Osman Ahmed. He is going to talk about practice development. Thank you.
In true little brother fashion, you gave me the honor of speaking after Yuji, which is pretty much impossible to do. So thanks, everybody. Thank you, Asahi, for the invitation. I'm going to talk about basically what I think I've done well in my career, which is practice building, both in academia and now that I've seen the light outside of academia as well. So, I think in general, nothing is easy, right? But with MSK embolization, there is a very big opportunity. I think it's basically because there is a true treatment gap. I think if you look at things like prostate embolization, sure, it works excellent. But the reality is that there's a lot of surgical options, and we're essentially competing directly with urologists. Whereas with MSK embolization, there's estimated 5 million patients alone in the US who basically have medically refractory disease that's not amenable to surgery, whether they can't have it or don't want to have it. So these patients literally have no other options, and they're just sitting there with pain. So there is a basically pool of patients that sort of need procedures like this. And so much that oftentimes these patients are desperate. They're paying out of their pocket for things like stem cells, PRP, other experimental things. So, I think in general, practice building is, very straightforward in that it comes down to the basics, and the classic 3 A's are always very important, being available, being affable, and being able, right? So we talk about being available. That means, always sort of having a quick response time, whether that's, giving out your cell phone or your email, but then it's also not just you, it's also your staff, right? Oftentimes your staff is actually the gatekeepers, and so you making sure that they're also available. I literally actually texted my staff while listening to Yuji about a patient that I just got referred. So just being able to sort of get patients quickly through the door is important. And then of course, being friendly, looking to help, offering these sort of providers a solution is very important. And then being able, you obviously have to be able to do a good job. And I think, Yuji showed very nicely, what we can do with the skill set that we have and how we can sort of treat these patients safely, effectively, and efficiently as well. So, just very briefly about my journey, I was inspired by Yuji's work back in 2019, 2020. This was about 5 years after his initial publications, and this was a very nascent field at the time. And really, I think Sid and Sunny were kind of the only two people that I knew personally that were doing it. So I really relied on them as resources to start my practice. But I think things have changed a lot. But initially when I started, there was a very, very strong opposition to GAE, especially because at the time, and they weren't wrong. It was experimental in the U.S., and so I think instead of being upset, I really used that as an opportunity to actually try to grow this and sort of, it's been amazing to see what's happened in the last 5-6 years, but really try to, do this responsibly. And so I obtained an IDE from the government and started a sort of very small pilot study. And as you can see, though, there is a treatment gap. There is a need. And this was just my U of C experience before I left. You could see the volume, was basically on an exponential curve, so much so that our compound annual growth rate was about 40%. And we hit some fun milestones along the way. This was our 100th patient that we treated and a 104-year-old patient that we treated. And so it was really rewarding to kind of build this practice. And just as a corollary, that took about 3-4 years to get to 100 patients in the university. I think within 6 months of being in private practice and sort of focusing or dedicating my career to this, we were able to reach 100 patients. So there, like I said, is a real opportunity. So how did we get here? This is really probably what the sort of meat of my talk is these are some of the pearls that I've learned along the way. I think the first that should be obvious, but sometimes doesn't appear as obvious, is that there's no gatekeeper of OA. Unlike prostate, unlike fibroids, unlike hemorrhoids, this is a disease managed by everybody and anyone because of so many patients there. So it's really sort of incumbent on you to sort of knock on everybody's door. You can see this sort of map that I've sort of shown that how many different people sort of manage these patients. And that actually includes IR too. So before GAE, we were managing these patients too, right? Whether it's steroid injections and things of that sort. And so because of that, there's opportunities to sort of get referrals from many different sources. The second pearl that I would say is don't be a one-trick pony. I think if you really want to invest in this space, as I just mentioned, as radiologists, we've always managed knee-OA for a long time, whether that's diagnostically, but also, we've always done injections. We've always done sort of pain management things like nerve ablations, and very recently, myself, we've started doing peripheral nerve stimulators as well. So you can be very comprehensive with how you manage these patients. And, I think as I've grown in my career, I've realized, you don't want to just sort of see a patient, do a procedure and say, oh, it didn't work, and then send that patient back. That's not as helpful as seeing a patient, trying something if it doesn't work, and then offering 2 or 3 different things. And we have this skill set to sort of do all of those. So because of that, it's really, I think, very helpful to build a comprehensive program, because then if you try multiple things, your outcomes inherently go up. And so that's ultimately what we want. We want patients to be satisfied, and then the referring docs are also satisfied because you found a solution for them. It doesn't have to be necessarily GAE. And then the third pearl sort of in that line is, you want to take a different approach with different specialties. I think surgeons and basically non-surgeons look at diseases very differently, right? And so non-op docs are focused or trying to get their patients solutions without thinking of surgery. So this is an opportunity to sort of do that for those docs. Whereas surgeons, just like, they want to cut everybody, right? This is just the kind of the stereotype. But the reality is there's a percentage of patients that they can't cut. So those are the patients that they are often, looking to sort of refer to you, or the patients that they've operated on that they don't, can't operate on more. So that's sort of, philosophically a different approach to somebody who's looking for a non-operative approach. And so that leads me to the next thing, which is I think GAE has significantly advanced, in half a decade. But the reality is still most non-IRs, most referring doctors don't know what GAE is, right? And so it's practice building in this situation is not about competing with your neighbor. It's about actually just educating, these referring docs. And so I think, again, back in the day, it was trying to do this through research, but now it's a lot more sort of understanding this is no longer experimental. We just published, the SIR position statement, sort of identifying that the data is pretty mature now. We have CE mark approval in Europe. We have multiple IDE studies. So really sort of using or harnessing that data to sort of go out and educate and sort of say, hey, look, this is not just some crazy procedure being done in Japan. This is something that's being done in the world. And we have a lot of good data to support it. Obviously, national media coverage helps, so things like this, Washington Post article really help legitimize this as well. And so just using this as an opportunity to educate both patients as well as referring docs. With that said, you still opportunities to grow through research. It is, while it is, I don't think it's necessarily experimental, there's still a lot more we can do, right? We have a lot more studies that are being underway. And I think anyone who's looking to get into this, whether that's through a registry or a clinical trial, those opportunities exist, and I would highly encourage you to do this before insurance denials and things like that will force us as a specialty to do that. And this is just our RCT sham study that we just transferred to the University of Utah any day now. And then, just some publications we've had along the way, just the opportunity to sort of, this is another opportunity to educate is just through, doing these types of studies. And then, I think the other important thing is, find stakeholders that are really, really interested in this. I think in a lot of things, you just need one or two really, really good docs that believe in this, that manage this disease, and they become kind of your, best referring docs. So this is just an example that at the university that, we built a very, very comprehensive program with multiple specialties. So we weren't in a silo trying to compete with people. We were trying to integrate this procedure into the paradigm of knee-OA treatment. So just to conclude, I think GAE and MSK embolization as a broad topic or sort of field is an exciting new arena in IR. It takes a lot of work, but there is a real treatment gap. So the bar, I think, to build the program is a little bit lower than other things. And I think this involves in sort of engaging multiple different specialties, finding patient solutions, and as well as research. So thank you, guys.
Great presentation, and I think what you said about getting involved in research resonates really well with me. And I always make joke about, it was internal joke about the fact that you left academia. I love everything about academia. What I don't like is administration. But honestly, when I started the OBL work, I realized the importance of doing good research through universities. And of course, we have a little bit less requirement or pressure to do that in the OBLs, but clearly all of us rely on really good quality research from academic institutions, and we need to support that. And one survey at Mayo Clinic many years ago was sent to patients, and the question was, why would they come to Mayo Clinic? And the first answer was because Mayo Clinic is involved in research. And so I think for anybody who does any practice, you need to know that doing research is another way of promoting your practice as well. So Kavi is my other little brother who is going to talk about a super selection in Y90 patients.
So Jafar, I'm going to point out that you gave me the non-MSK topic. And so I get to talk about the maybe the less cool stuff today, but no. In all seriousness, I appreciate the opportunity to be here, and we're going to pivot a little bit. And I also do a lot of MSK embolization, but the other hat that I wear in my practice is obviously we all do a lot of general embolization, but then I do a lot of liver cancer therapy, and really this space has evolved to ultra-selective delivery of our therapies and embolics, and so we'll go through some of that today. So quick disclosures. And then it's always nice to start with the case, right, to kind of solidify and drive some of this home. And I don't think I have a laser pointer, I apologize, but you can kind of see this is a post-stroke patient, had a G-tube placed, and you see the contrast blush literally right next to the G-tube there anteriorly. I think I have an arrow, yeah. And this is actually the second time I was on call this night. My partner had taken the patient for angio a couple of days prior, had taken down the inferior epigastric artery on that side and the superior epigastric artery on that side, and this patient was still bleeding. So I went, my plan was to actually take down the left gastric and or the gastropoploic. The challenge was for this particular patient, as we rolled through this coronal scan, he had a history of a coarctation of his aorta and a bypass graft, and he had no celiac artery origin. And you see a very, very large SMA collateralized to take over the celiac, and you see the blush here posteriorly there, or anteriorly there, sorry, right next to the G-tube balloon. So not the most straightforward catheterization. This was the initial arteriogram. You see the well-developed pancreaticoduodenal arcade to the GDA, very tortuous, supplying that entire territory. And then again, so my plan was left gastric and gastropoploic. And so those of you that know me, my starting catheter, except in very select situations, so like proximal spleen, internal iliac embolization for trauma, maybe variceal bleeding, BATO, BRTO, I might start with the 2.8 microcatheter, base catheter, microcatheter combo. But everything else in my practice, I start with a 2.0 or below. It's very common for me. You get great injection rates. I can get anywhere I need to. I can deliver most of the embolics that I need to. And I'm a primary liquid user at baseline, outside of the MSK space, right? So I started with the 2 French catheter here. And that catheter tip is all the way in the left gastric branch. I couldn't get the 2 French catheter to go. So I pulled everything. And I went back with a 1.9. And I still couldn't get it to go. And I pulled everything. And I went back with a 1.7. And that's how I finally got there, right? So only able to get there with the 1.7 catheter, used lava, embolized, went back to the gastropaploic, didn't see a blush here or a bleed here, actually from either side, but this guy was in extremis. The catheter tip is all the way out the gastropaploic. This was a 1.9, embolized with lava here as well. And then on the post-run, both the gastropaploic is truncated and the left gastric is gone, and this patient got a little bit better. So, but challenging case, different tools in the toolbox, moving away from that standard. I'm going to start with a 2.8 or a 2.4, right? That would have added a lot more time and failure to this case. So, we all talk about ALARA, right? That's a radiology thing. And so this has been coined CASEP, or catheterize as selectively as possible. I'm very curious if Oz is going to like this acronym or not. I haven't showed this to him before, but we'll see. But we know this, right? Better outcomes, less non-target embolization, and really in that era of ultra-selectivity, it's 2 French or less, right? And we are there. We have those tools. And looking at this particular article from the Journal of Japanese Radiology, selective embolization is specifically tied to optimized prognosis and survival, right? So again, we have data that supports this. So the catheters that I have on my shelf, the Asahi Volute, 1.7 tip, 0.17 ID at the tip, accepts an 0.16 wire. I prefer the angle tip, but the straight tip is available. And then the TELUS, which is the 1.9 catheter, I have this on the shelf as well. 0.19 at the distal end, also accepts an 0.16 wire. Again, I prefer the angle tip over the straight tip. We'll talk about why in a second. And then a braided shaft, right? And so this braided proprietary technology, thick wire, thin wire technology, allowing for flexibility, the lack of kinking, lumen retention, and optimized pushability as well. So a quick note about the power or optimizing flow rates. You would think, 1.7, 1.9, well, I'm not going to be able to get great contrast runs, but as you can see, even with the 150 catheter and an IsoView 300, you can get 3.2 cc's per second through the 1.7. Compatibility is important when we're talking about small catheters. We don't have a lot of coil compatibility, but particles in particular, Embospheres 5 to 7, Embozine over 500, but compatible with both catheters. Again, I'm a primary liquid user, so I'm using a lot of liquids in these situations. And then what's the data, right? We all want data around these kinds of, as we evolve in these spaces. And so there is some data. And so these are a couple of series out of Japan. Leave it to our Japanese colleagues, as in the MSK space, to really pioneer the direction that we're going, and then for us in the US to continue to follow, right? And so 9 patients with GI bleeds, 1.7 microcatheters, 0.5 millimeter diameter blood vessels, all successful. Another series a little bit later, 17 patients, again, 1.6 triaxial system or 1.7 microcatheter, slightly larger vessels, again, 100% technical and clinical success. What about cancer therapies? This was 36 patients, 68 tumors, 1.9 French microcatheters, ultra-selective TACE successful in almost 99% of vessels, right? So they picked off individual vessels as opposed to giving segmental or lobar TACEs, right? We know that is less optimal, worse outcomes for these patients. We have to be more selective. You can get selective and be successful. CPN, why is this relevant? We'll talk about this in a couple slides, but this is ultra-selective TACE with basically a RAD path study. And so when they explanted these tumors, 7 of 9 have had complete pathologic necrosis, which is very high for TACE. Those of you that have seen the TACE CPN data, that's very high for TACE. And when they looked at the lipidol retention in the tumor, grade 2 portal vein staining actually correlated with normal liver parenchymal necrosis around the tumor, effectively a TACE margin around the tumor, which is what we shoot for with thermal ablation and sometimes with Y90 as well. What about hypovascular tumors? We had a great data set that came out earlier this year from the University of Colorado. Hypovascular on cross-sectional imaging does not equal hypovascular on arterial cone beam CT. We all know that, right? We've all been in that situation. What happens if it is truly, truly hypovascular? Then you get ultra-selective, you deliver your embolic, and it can change the TNR. We know that. Some of Shamar Young's work, actually with Jafar, you can optimize your TNR by being ultra-selective or super-selective. Same thing here. 68% of these 47 HCCs, they got super selective, delivered TACE with Lipiodol, actually able to paint the entire tumor and treat the entire tumor. Guidelines, right, again, overseas, our international colleagues are a little bit ahead of us with this space. This is from the Korean Liver Cancer Association 2023 expert consensus recommendation. Specifically, 1.5 to 1.7 microcatheters should be primarily used for super selective TACE. Nothing above 2 French should be used, and TACE should be conducted as super selectively as possible. When they polled and surveyed their providers in the country, the vast majority of them, greater than 90% of them, are using 2 French or less microcatheters. So it's already happening. We have to catch up. So then back to CPN. This is the relevance, right? CPN is the important endpoint that we are now aspiring to. It's not just radiologic response. It is truly CPN. So this was a TACE study, initial responders, objective response, and initial CR on imaging, portended better outcome, even compared to later responders or later complete response, right? Specifically related to CPN, these are 2 large cohorts from Agopian et al. And Denorsi et al. Over 3,000 patients, all had HCC, all had local regional therapy, all had transplant. What you invariably see is that CPN after local regional therapy has better overall survival, better recurrence-free survival. So that is the target, not just complete response on imaging. What about for Y90, right? Y90 is now the primary bridging therapy in the U.S. This is what we're all doing in the U.S. As a first-line therapy. This is a nice recent study from the WashU group, 38 patients, 16 of them in that ALB2B category, 42 tumors, mean perfused volume, very small, less than 70 cc's, very high complete response rate, high pathologic necrosis rate, very little change in lab. So very much a ablative liver-sparing therapy now, right? So the challenge is, how do you convert Y90, though, to this ultra-selective mentality, right? And if you look at the GLASS Y90 IFU, it specifically says greater than 020 microcatheter, which is basically 2 French or greater, right? And not all 2 French catheters are also made the same. So we looked back at our own data, and we're commonly using 1.7 and 1.9 catheters in this situation. So on the left side, this was a lady with colorectal mets that I treated, multiple lesions. I gave 4 selective doses. One through a 1.7 Asahi microcatheter, 80 cc perfused volume, 10 GBQ vials, so that means 2.5 million particles, more than 99% of the dose was delivered. On the right side, it was a 1.9 French catheter. This was a large 14 centimeter cholangiocarcinoma that I treated, again with multiple ablative selective doses, 160 cc perfused volume for this target territory, 13.5 GBQ vials, so 3.375 million particles. Again, over 99% of the dose was delivered, right? So you can go below, although it is off-label, you can go below and make this work and get more selective. What about triaxial systems? This was a nice little paper from 2022, a coaxial microcatheter system through the base catheter. To my knowledge, something that's not available in the US yet, but hopefully we do get to this eventually. A 1.6 inner microcatheter over an 0.14 wire inside of a 2.8 microcatheter. Improved stability, improved torqueability, and then preserving your outer microcatheter in a super selective position, right? When you're using a liquid embolic, when you're using a radioembolic. So that's a really nice advantage to have once we get there. In this study, they also, of the 10 procedures they did, all successful. Actually, one was a resin Y90 delivery. So nice to know that as well. And then I think floating microcatheters. Again, off-label. Hopefully this plays. Maybe this will play. There we go. So again, off-label, we talked about it already, and I do this all the time in the liver. This is my preference. I will get my base catheter to the place it needs to be. I will push my microcatheter in, and if I can navigate, now it is not one-to-one torque, but if I can navigate to where I need to be, I will save time and have a more workflow efficient environment in my angio suite, right? So commonly doing this to the best of my ability, and that's why I use that angle tip like I alluded to earlier. So in conclusion, ultra-selective needs to really now be part of the repertoire. General embolization, MSK embolization, tumor embolization, absolutely. Really need to have those tools on the shelf and know when to go down those roads. Compatibilities, I think we still need to learn a little bit more, so those will be hopefully coming soon. And then obviously there's the balance of trackability and torqueability, right? And I think that's where that floating of your microcatheter comes into play. Again, I tend to do that a lot. Hopefully we'll continue to have iterations of device that enable that as we go forward, and then same with coaxial systems. Thank you to my team, right? Everything is always a team. Oz mentioned that, Dr. Okuno mentioned that. I have my interventional radiology colleagues, I have my radiation safety colleagues, I have my nuclear medicine colleagues, and then obviously the ASAE team. So, thank you.
So, as we were talking about 20th anniversary of GEST, I have to admit, I am so impressed by the quality of this young generation. You guys have done amazing presentation. I am really sure that after Mahmoud and me, we retire, the future would be really brilliant. Well, I couldn't find older, sorry. We go back, way back. So great topics. One of the things that you say, Kavi, and is music to my ear, because I have been trying to do that at the University of Minnesota for many years, and that's following the Japanese technique. Dr. Miyayama, Dr. Tanaka is here, using smaller microcatheters for TACE. And of course, when we started first to show at guests, at the time of COVID, using this microcatheter, smaller, pushing without wire, a lot of people started to text us and say that's a crime, you should not use microcatheter without wire. Just wanted to ask, how many of you actually use this technique, just to advance small microcatheter without wire? How many things is a crime? How many things that you have to use a wire? Sid Padia would be here, who would say, no, I have been taught that I wouldn't use wire, I shouldn't use wire. Anybody is convinced that you have to use wire for every microcatheter? Okay. So there are, when I look at Okuno, I don't know how he does with Volute, every single catheter vessel he can go without wire. But when you can't do that, and I have been in one case, you use micro wire. What's your choice micro wire in those situations?
So we usually use a Meister. Asahi Meister microcatheter. I think the torqueability, one-to-one torqueability is very good, and also the reshapeable, and yeah, it's very good.
Very good.
Yeah.
First, any question from the floor? Because I think having those experts here, it would be good to have some interaction. Any question? Kumar?
Great talks, guys. So are we done with the imipenem concern for resistance in the U.S. at least? I know Japan, it's easy to use, but Kabi and Jafar, I know this is still something we think about. We talked a little bit about the data or research. Are we clear for fewer imipenem usage without concern right now?
Using imipenem without concern?
With the resistance concerns. Are we clear from that now?
I will let you comment, and I will give you my opinion. I am using imipenem, but I will give you my opinion.
I don't know if this is working. Oh, it is. Yeah, no, it's a really good question, Kumar. I mean, I think the reality is in the position statement we have mentioned imipenem as a embolic that's used for GAE. It's probably the one that's been studied the most, right? I'm not aware of any data that suggests that there is increased antibiotic resistance. I don't know if it's because of the amount that we're using or whatnot, but I do think that whether it's a real concern or not is the impetus to evolve beyond it, to other embolics like resorbables that kind of have similar functions. So similar to Jafar, we do use it. I think we use primarily Lipiodol now because of the breakthrough designation and just obviously it has similar efficacy and safety data. But whether it's safe or not to use, I think there's really no hard data on it one way.
Yeah, we published at CVIR last few months ago a review on imipenem, and there is no data, but I have a serious concern that there is a risk because there's a very strong antibiotics. But the data going back to 1991 that has been used in Japan, and we look at literature, we look at a lot of publications. We haven't seen any data confirming that, and it needs some animal study. And I heard that there was an animal study done in France. They have not published it. But what they have seen is that within 24 hours, all of the gut biome were dead. And that can raise a concern. So we can't extrapolate the animal data with one study that is not published to this, but I still talk about that as a serious concern.
Yeah, I'll add, the only way that I was able to get imipenem on my shelf was it was a 2-year runway until other resorbables came. And that 2 years is almost over. And so I've, like Oz, have switched to mostly Lapide joint at this point, or Lapidol. But that was the only way, showcasing, you know, whether we agree with it or not, the low risk of permanent embolics, and then using that as a mechanism to have on the shelf.
Lipide joints, you said there's breakthrough indication for knee embolization.
Mm-hmm.
Can you expand on that a little bit? Should be open.
Did you read the paper that you're co-author on?
Well, it's for people to listen to hear. If I ask the question for which I don't have the answer, I should sit down. It's not my modesty.
You got to give it to your big brother whenever you get a chance, you know. So so no embolic in the United States has an on-label indication for musculoskeletal embolization. In theory, we're using every single device off-label for embolization in GAE. A few of the products in the U.S. have what's called a FDA breakthrough designation, which doesn't mean it's on label, but basically means that the FDA has identified that this is a high priority thing, and that they're sort of supporting sort of fast-tracking studies to sort of understand that. So along with Lapidol, I believe Embozine does and Embosphere does, and then Nexphere and CranMed are both currently enrolling, or CranMed's is done, but they're doing IDE studies for on-label indication. So there's basically 5 embolics, that are kind of in the works.
Yeah, we'll talk about that actually in the next session on the master class. So Yuji, I feel that there is a shift in your practice for plantar fascia, because but your paper that you published, you said at the beginning you did intraarterial, then you switched to direct puncture, and now you are going back to intraarterial, selective catheterization, and direct puncture is only after you failed before the first one.
And for example, for knee or elbow, it is very obvious that super selective is better, because we cannot achieve the same packing density when we do the direct puncture method, because the target vessel is little bit far from the popliteal artery, from each genicular artery is very far. So we strongly recommend to knee OA patient to receive super selective GAE. But for the plantar fasciitis patients, maybe we can have some space, like your institute do that multiple embolization in a single session. We can improve more, better single super selective embolization better. But when from our initial experience, the direct puncture results is good for plantar fasciitis, because
the average procedure was 2.3
single
per patient.
Yeah, single is not enough.
Yeah, because I think Amin presented that, and we talked about that on MSK Day on Sunday. We switched to a technique where we embolize from PT, and if we wait 5 minutes. After 5 minutes, if the blush is back, which is back almost in 85% of cases, then we go super selectively and embolize until the blush doesn't come back. And we saw that the recurrence rate is much lower.
Yeah, and now we are switching from imipenem to the other resorbable, in many reasons. But in Japan, the imipenem is too much cheap. Because the government sets the price, and it is about $6 for one buyer.
Japan is FDA, from what I know, is one of the hardest in the world. So you don't have any limitation to use imipenem as an embolic?
In off-label use, and in so our practice is self-pay practice.
Yeah.
So government insurance doesn't cover.
Okay.
So we can use that in that off-label use, but but recently we switched to the Sakura beads. We began to do the direct puncture for plantar fasciitis with using Sakura beads, and the results is good. So I think maybe
And then one question for. Any question from the floor, by the way? We have just 2-3 more minutes. Go ahead.
How do you decide direct puncture
How to decide between direct puncture or catheterization?
It's faster, easier, use less material, patient feels
Yeah, main reason is the financial aspect. Patients have to pay by themselves in our country.
Direct puncture, I don't know in the US, anybody knows if we do direct puncture and inject embolics, is it considered embolization or not? Well, that's one question. It could be because you're injecting something to close something, but so if you explain to the patient that from the data published by Okuno, you can do direct puncture, but the chances that this patient has to have an average of 2.3 intervention, so you may explain to them and you may come back and do this again, then I think you can definitely do that because that data is very convincing. Now, for our patients, we prefer to give them one shot because we don't know if they are going to come back or they will probably not prefer choosing a puncture there instead of puncture back there. I don't know. It's the discussion, it seems that if we do intra-arterial, you have much less chance of recurrence. Any other question? Last question?
Is it really working out if patients have to come back for embolization with direct puncture 2 to 3 times? Does that really work out more cost effectively for the patient?
Can you repeat the question?
Yeah, so if your patient
Cost.
coming for 2 to 3 times on average for a direct puncture versus intra-arterial catheterization, is it working out financially beneficial?
Oh, the question was if the patient comes and has more puncture versus intra-arterial catheterization is financially going to be more beneficial for those patients.
Yeah, so it's we have to examine that. Yeah, so we so we set so it depends on what price we charge. And
yeah, I don't know in the U.S. what honestly I think we should ask that question from those lawyers that were here at the OBL session. But it's a good question. What do we charge for a direct puncture? But anyways, none of our patients in the U.S. can afford to pay out of pocket for any procedure anyway. So I would like to thank you guys for a great presentation. Thank you for all of you who stayed here. Thank you, Asai, for an amazing session. And